everybody. Welcome to Health Impact Digital Health Talks. This is Megan Antonelli. And today we're talking about one of the, most important questions really in healthcare and the adoption of AI and telemedicine, which is, how much, are consumers and patients interested and wanting to be, involved in and have AI participate. So today our guest is Andy Flanagan, CEO of Iris Telehealth and one of the nation's leading behavioral health telepsychiatry providers. Andy brings a rare perspective at the intersection of clinical care, consumer trust, and AI-enabled mental health delivery. Today, we'll talk about what it means for health system leaders, CIOs, and investors in behavioral health, and of course, patients in terms of the implementation and deployment of these amazing technologies. Hi, Andy. How are you?
Hi, Megan. Thanks for having me.
Yeah, so glad to meet you and have you on the show. Tell our audience a little bit about Iris Telehealth and what you guys do.
Sure. Iris is one of the earliest telehealth companies specifically exclusively focused on telepsychiatry. We employ over 600 clinicians. We operate in 45 states. We're in emergency departments and medical surgical floors. And of course, we do a tremendous amount of outpatient therapy. So we really are seeing all patient journeys, all demographics, and all diagnoses. And as a result, we're focused on efficiency, clinical outcomes. How do we use technology to the fullest in a safe and responsible manner? How do we continue to provide access to people that need it?
Yeah, that's great. I think that the application of telehealth, certainly in telepsychiatry, was one of the first and certainly one of the most widely adopted. And as you're, sort of looking at the market now, I know you've done a lot of research in terms of consumer acceptance of AI monitoring and mental health risk detection. Tell us a little bit about what you found.
Yes, fascinating. First of all, there's a point in which we all are comfortable with AI until we're not. And that moment is the AI cliff. That's what I call it. It's the moment in which we say, okay, hold on a second. It's a little bit too much. Amazingly, over half of us are comfortable with 24/7 monitoring of how we're doing passively. So imagine every time we're on our phone, an AI agent is saying, how are you doing, Andy? How you doing? And it's looking for indicators of stress, anxiety, depression. That's all capable today. The important thing is that if we go back just 2 years, the percentage of people that would say I'm comfortable with that probably be 10%. So there's a huge maturation about our knowledge and comfort level of what's really going on here. Now, at the same time, 93% of us want a human in the middle in an emergency situation making a decision. So there's the cliff. Monitor how I'm doing, give me some clues, tell me. But if it's a clinical decision, I want a human. In a non-emergency solution, it's 73%. So at the least 73% of the humans would say, it's okay for you to monitor me, but don't make a recommendation. And that's a very responsible maturation of this technology.
Yeah, no, it's so interesting. I mean, when you think about, I immediately think about sort of my customer service calls in my life, not necessarily my therapy calls, but customer service calls where maybe a therapist's intervention would have been a good thing.
Yeah.
But,
all identify with that.
When you think of the sentiment and the, being able to sort of assess people's emotions, right? I mean, and there's no way that, AT&T wasn't doing that at some point when I was on the phone with them talking about my cell phone,
For sure. That's right. For sure.
Right. But those applications now to what we can, sort of see and I obviously with sort of mental health and telepsychiatry, but also just assessing where there might be that need to kind of bring the patient over to that human intervention, right?
That's
so
right.
Tell us a little bit about, to go back a little towards sort of when Iris Telehealth was founded and kind of the gaps in the market that really, kind of brought you guys to where you were, providing this need.
Yeah, so we started out working with community mental health centers and federally qualified health centers. So think about heavy Medicaid, Medicare patient, populations, high acuity, polychronic. both urban and rural, really. But the fundamental problem we solve is a lack of access. Somebody has a need, but it takes 4 to 6 months to get to somebody, right? So by partnering with these community organizations, it led us to the health system market naturally, specifically the emergency department first, and then outpatient. And it really fits our own journey that we all live. We come in and out of health systems networks for oncology or, musculoskeletal, whatever our journey might bring us. And the behavioral health is ever present. It's like our physical health, right? It's always there. But the network for behavioral health is much more fragile. There's not as much money in behavioral health. Clinicians don't make as much, and therefore there are fewer of them. And so Iris really early on, 2013, started solving this problem about in a clinically efficient and effective manner, providing access remotely, digitally, fractionally. And really our customers have pulled us, really almost all of our growth comes from our existing, we call customers partners, because there's just so much work out there. Unfortunately, so many of us want help and there just aren't enough clinicians. So the online prescribing, like we were doing this digitally back in 2013, very close and present around the DEA and X waivers and a lot of the enabling safety protocols.
Right.
And really both psychiatrists, APPs, and licensed clinical social workers all can, in a peer-reviewed, clinically effective way, be as efficient and effective in person as you can virtually. It's one of the very few practice areas where that's true.
Mm-hmm. Yeah. And I think as our sort of generations become more digital, it's even, in some case, more effective, right? I think that, the access and the almost preferred method, when I think of certainly adolescents and kids. Now, in terms of where are you guys available everywhere? Is it
We're in 43 states today. We see, 40% of our panels are pediatrics, geriatric. We see all levels of acuity. We're in emergency departments, as I mentioned. So, we really have a very broad footprint. We're one of the few groups that actually serve entire populations. So we can work with a health system or a community and say, we can support your entire patient panel. A lot of our peers who are doing fantastic work, this isn't a competitive zero-sum marketplace. So they're respected peers. They'll focus on OCD, or they'll focus on pediatrics, or they'll focus on geriatrics. And that's high quality work and very hard to do, and they do it in a great way. Our job is to really be a generalist as good in each of those areas. And that allows us to be a partner of scale. So we can work with an entire health system across all service lines, all locations, across multi-state. And so we skew towards the larger end of the market, if you will, in terms of our footprint.
Yeah. No, it is. And it's such a hard position to staff within the hospital organization, but then to serve, sort of those multiple markets and communities.
Yes.
And so in terms of how you're applying AI in terms of the monitoring and kind of how you got there, tell us a little bit about that.
Mm-hmm. Yeah. So, I'm primarily a software person by background and education. And so I've very carefully, leading a medical group, been very judicious about where software has a job. It's not easy for me, but it's a very strong team, thankfully. We really started in the simple area that in behavioral health, we have to recognize that the data and the infrastructure and the resources, the consultants, the revenue cycle resources, it's like 2005. The money just didn't flow here. And so in many cases, you have community organizations that can't pull an accounts payable report. It takes them 3 days. So they don't have the fundamental clinical outcome data already linked in that's present. They're not always using Epic or Oracle or, and so we started there. We started with analytics. We started with a data lakehouse. We started helping people just get the KPIs that matter in managing your referral queue. How long are people waiting? Are you assessing the demand inside of your queue? If you have somebody who might escalate to the ED, we probably want to have some resources that could de-escalate them. So when we implement, we take these patient journeys, we pull them apart from a data perspective, and then we build a medical group around what we learn, as opposed to saying it's one size fit all, just do it the way, just first in, first out. So we started with analytics and infrastructure. We then moved on to machine learning algorithms to predict ED utilization. And now you start to say, boy, who would not like to avoid an ED visit, right? And so now we're partnering with our current customers on how do we deploy a predictive algorithm, machine learning algorithm, across their entire patient panel, employees and otherwise, to provide proactive resources. That's not traditionally how behavioral health has been deployed, or it's a reactive science, right? So we have stayed away from ambient listening because we use the EHRs of our customers, and they are making those technology decisions. So we believe we use anything that's already paid for, we'll use that technology. We don't want to add costs to that story. We're not a software company. We want to be, the key for us is that we're completely integrated into the care workflow. And so this idea, most of the market refers out to a third-party group, and then the patient goes and the clinical data stays over there. We believe all the data needs to be in a central store where the PCP and all the other specialists live, even though it's behavioral health.
Oh, wow. Yeah. So, in essence, you're, taking the data that's given by the partner or provider that you're working with. And then how does that come into this risk assessment and that next level of AI involvement that we were talking about?
So we developed the algorithm and calibrate the algorithm nationally so that we can say, out of 200 data elements, we know the 19 that are most material that predict ED utilization. And so you take an 800,000 patient panel or a 2,000 patient panel, and you apply this algorithm and you say, these are the 38 people, or these are the 8,000 people that are likely to present. Let's make sure that they're getting care. Is there any evidence of any therapy, any medication? And you want to find, you're triaging. So you're looking for somebody with no evidence of any access whatsoever. Wow. That's where you usually see prior ED utilization because,
right.
Homelessness, transportation issues, all sorts of things that go into socioeconomic determinants of health and BH. So that algorithm we built, and then we tune it for the patient panel that we work with. And these things are self-learning, right? The more you use it, the better you get at it. And the real key for us is to match the clinician's supply to this demand. So when you inject a whole bunch of more demand, you say, well, wait a minute, I don't have the clinicians. And so it's this tricky balance, Megan. Like you're always titrating back and forth because the goal is you have to be profitable, right? No money, no margin, no mission, right? Mm-hmm. You have to make a ton of money, but you just can't have negative money. You can't have no money.
Right. Well, especially, when it comes to kind of the critical behavioral health investments that leadership is making, you've got to show sort of value behind that, right? And so it sounds like that's here. Now, going back to the discussion of the study and kind of consumer acceptance of all of this and where that fits in, obviously there's also a number of regulations happening and another, sort of behavior, change in terms of acceptance in terms of where people want to get their healthcare in general, telehealth and sort of acceptance around that. So tell us a little bit about what you're seeing, both with the research that you've been doing, but then let's talk a little bit more about the broad picture and how those two things might, dovetail.
Yes. So telehealth has moved into a mainstream modality for health systems and community organizations and as consumers, right? We'll accept it for dermatology or for primary care. And so all these things are reinforcing behaviors, if you will. But on the health system side and the community side, they are deploying telehealth across primary care and dentistry. Like it's part of how they do business. Part of it is it reduces physician burnout. They can see patients from home. They get a chance to not commuting every single day. And that provider retention and satisfaction is so important, right, for everybody. On the clinical side, we're seeing a lot of evidence supporting the idea, certainly in behavioral health, because that's been well established that it's as effective. But you're starting to see care pathways be nibbled at. Take the GLP-1s. The follow-on monthly prescription call is a perfect use case of how are you feeling? How are you doing? How's your weight loss? Okay, I'll renew the prescription. It's a relatively safe, and so they can, therapy. And so these little edge cases clinically are growing dramatically. They're growing quickly. And so the infrastructure, not wars, but the providers, the early people in telehealth that had carts and software, and we see them now as public companies that are kind of struggling, right? Well, it's because it's become ubiquitous. It's no longer a proprietary technology, which is a great thing for us. So that's the first thing, that telehealth is moving mainstream. And I think that, the PHE and telehealth capabilities and the extensions, all of that is a bipartisan story. So I'm confident that that train will continue to go. The rural health transformation, $50 billion investment. If you look at the use of proceeds for most of the RFPs from the state, infrastructure for telehealth, infrastructure for data, digital health, digital engagement. So now you start to see over a 5-year period, a ton of money showing up, right? $1 billion a year for every state for rural. It's a little bit like, the High Tech Act for EHRs. This is going to really drive significant penetration of innovation into the rural communities, which needs it more than anybody else, right? We have partners in, Borden region, Texas, where it's a 400-mile catchment area. You're going to drive for an hour therapy session? Like, that doesn't make sense, right? 200 miles? You're not going to do that. So and the rural health funds, I think, are going to have a huge reinforcing, kind of high tide for everything. And it includes AI. The administrative use case of AI, revenue cycle, you just can't state it. It's going to print money for people that should be paid appropriate reimbursement. And certainly on the clinicians, ambient listening is, 5 minutes per appointment, 20 appointments a day. The pajama time where they're at home finishing their orders as opposed to saying, here's the automated summary. I get to review it. I'm done with 1 to 2 to 3 minutes, not 20. Huge lift, not necessarily accruing just to the bottom line of the health system because you can fit one more appointment. I think the bigger lift is it's really affecting physician satisfaction and retention.
Yeah.
So those are the kind of pillars, if you will, like mainstream telehealth, and AI use cases are happening in so many different places. And every time it happens, the nurse and the patient are also consumers. They're on with their clinicians the next day remotely. It's a self-reinforcing wheel. We're seeing this. Yeah. So I'm pretty optimistic that we're on the right path here.
Yeah, it's an exciting time for sure. I mean, it's just, it feels like that High Tech Act in that, for so long it's been, why are they going to do it? Where is the payment? Who's going to pay for it? Or why would they pay for it? It's counterintuitive too. And now that we sort of hit this sort of threshold of, well, the patients, consumers want it. It is the sort of standard preliminary, way, beginning of care pathways. And then, as you said, in terms of sort of that follow-up compliance, there's just so many applications. And then the AI kind of making it all possible and easier and a bit cheaper in some cases, making the sort of the threshold for it to happen just that much easier. I mean, I think just watching CES today, like Dr. Marty Macary's on the floor, sort of walking the floor, talking about, how progressive the AI, the FDA is being in terms of AI adoption, and that they, sort of putting themselves ahead of other segments of the government in terms of adoption. And it is a rare thing to see healthcare.
You never would have thought that, right? You never would have expected those words to come out. From that source. You're exactly right.
And but going back to kind of the importance of, and not only the need for, but the consumer demand for human oversight in that and the human intervention. Talk a little bit about, where that fits in with the Iris platform, and how you guys are looking at kind of rolling that out.
Yeah, so we have our own medical malpractice. Like we're fully accountable for our outcomes, and as such, especially like in emergency department work, these are fraught moments, super high intensivity of care, and so we think about it like everybody else does. It's been a huge lift for us in terms of understanding capacity modeling, understanding patient journeys, and matching clinician types. So, we need a triple board child psychiatrist. 40% of our ED visits are for pediatrics. And so, you have to kind of have these models that say, who should I hire and retain? Because it's not like you can just hire one tomorrow. These are long tenured employees at Iris, and, we're very careful on who we hire. So we have to be very thoughtful. So the technology has enabled us to be a profitable company in spite of low reimbursement, Medicaid, Medicare, a very challenging geographically diverse customer base, and high risk patient journeys. Those three usually mean either you get paid a lot of money, which isn't the case, or you have to be super efficient. And that's what we're really focused on. And so Iris has always been highly innovative. Right now, we're working on 4 new solutions as we come into this year that we think will match where the patient journeys really are most underserved. And we're leading with digital technology. We're leading with analytics and insights and AI, machine learning as well. If we think about the access model that CMMI put out, the RFA, and we're, I think 250 companies indicated, we were one of them, to apply for that model. So you've got, in behavioral health, the 4 tracks, kidney, cardiology, MSK, and behavioral health are the 4 areas. They want to work on innovation. Obviously, we're focused on behavioral health. 30 million Medicaid lives are involved in this program. And, at opt-in and all those things, of course. But it explicitly, the RFA explicitly talks about how can you use technology to produce better outcomes and better patient experiences. I mean, for the federal government to publish that, the RFA was published 2 weeks before the deadline they said they would publish it. When was the last time that happened? Never, right? So yeah, so we see a really bright future. We're really careful, and we are not really working at all on AI in a clinical decision-making moment. There's still so many opportunities administratively in coordination, scheduling, patient activation, follow-up, things that, there's just as much value there. And, we really kind of view that moment of the encounter as a sacred moment. And we just keep it in the middle. We're just trying to optimize everything that goes into and comes out of that patient experience for the provider.
Right. Which then I imagine, both sort of handles the resistance from the provider side and from the patient side, right? And that you're kind of intervening in the places where there's a sort of lower value, sort of to that, transaction anyway, right?
And it's value on, you're exactly right, Megan, because, how many of us, when we're having an experience scheduling and we're texting, how many of us said after the 3rd text, really? It wasn't clear? The first 3 texts, that wasn't clear?
Right.
I mean, we all have, it's back to your phone call with AT&T, right? Like we all know what that looks like.
Right. When it happens. And there is that, that point where you're like, okay, now I want the agent, now I want the agent, so I imagine it happening in this side too.
Uncle, done.
Now when you get, on the side of things where you guys are, at least my understanding is you have some monitoring of voice tone and facial expressions and things like that. There's that technology that's at play as well. Correct?
Yeah. And so that is inside the EHRs that we use. And so that decision would be made by the health system and we adopt uniformly. So our clinicians are actively using every AI platform that our clients have adopted. And so as a result, because we have hundreds of partners, 325 partners, and like one health system is one partner. So in terms of the scale of our sites of care, it's pretty broad. We probably have one of the most diverse medical groups in terms of experience with different AI platforms. All of them, right, would be the short answer.
Right.
And, we spend a tremendous amount of time in grand rounds. We're Joint Commission accredited. We do chart reviews. We're doing trainings all the time just to help them, kind of feel comfortable in the moment, leverage the technology. So
Got it.
It's not a free thing. It's just, you have to know what it's doing.
Right. And so within that, your medical groups actually are exposed to multiple different systems across these different hospital partners that they have. Wow, that would be an interesting, It is. You guys could run your own class.
Well, that's why we did the study, right? We said, you know what, we should help people understand what's happening. We didn't do this because we're selling AI software.
Right.
We're not doing this because there's some value in us promoting AI, economically or beneficially. We just said we need to help our industry understand what's happening, and we have a very unique vantage point. So let's go ahead and conduct this study and share the results freely. And I appreciate you amplifying this because we want people to understand what's really going on. And so that's
no, that's great. I mean, it is. And it's such a unique window into sort of the adoption and kind of the patient and also provider adoption too, where we'll talk about it kind of abstractly in terms of what do they like? What do they not like? How far do they go? But you guys are really seeing that. So that's, that's great. And it's great that you're sharing it. From a competitive standpoint, when you look at that, are there particular areas that, are interesting in terms of where you see success on the hospitals deploying this and sort of what people like versus what they don't?
The idea of data, the idea of technology is rarely native to our peer group of companies. They're usually founded by a clinician, run by a clinician. It's medically oriented, it's direct to consumer. It's much more of a traditional practice model. And because we're not direct to consumer, we're B2B, right? We're embedding ourselves into community mental health centers and FQHCs and health systems. We've really taken the lens that our managed service organization, our MSO, it's a friendly PC model. So you have the medical group and you have the MSO that does all the administrative services. It gives us the right to bring solutions that we think would beneficially help everyone be more efficient, have better clinical outcomes, and as a result, be financially successful. So what we find is that we in fact do. We have excellent clinical outcomes. The NPS score is 91. And our clinician, our customer partner satisfaction is very high, 64. So, we think these reduce friction and they help people see around the corner and better utilize the resources, which produces a better, more loyal patient experience. And that works. I think Iris Telehealth has an excellent brand. I think we have an excellent reputation. And I think our entire 800 employee group works really, really hard to make that way. It's incredibly difficult, Megan. I really am in awe of our company and our employees because we're doing work that you would not normally associate with being a behavioral health medical group. Why did you build a lake house? Why are you doing goal tables for that? Like what? But in the end, it's part of this bigger strategy of actually being the next generation level of efficiency and engage a higher level of penetration of people that need access in your area, in your catchment area. Our health systems can't get, in many cases, or even more FQHCs, the resources to do that work. They don't have the money. There aren't consulting companies knocking on the door every day saying, hey, I'll do this pilot for you. I'll do an MVP for free because I want you to be my customer. Nope, it's full free. Yeah. So I'm really proud of the team for investing in that because it is really, we don't really charge for that work. We just do it.
Yeah. Well, and I mean, it is. And it's so, when you think of all of the, sort of windows and unique vantage points that companies do have, and that they often do not share that information, inherently by policy, and that it is a really great thing that you guys are doing to be able to kind of provide that window both to your partners, but also more broadly in terms of adoption. And it's a critical time, right? Because we are in this, sort of middle of talking about, what will happen with home, healthcare at home and telehealth and across states, as well as this, the rural health initiatives. So, there's a lot of exciting things happening in that space. And we've always in both of these areas talked about the obstacles, right? I mean, the state by state regulations and things that make it very difficult. And you guys have kind of weathered that storm for the last, almost 15 years. And as things are finally maybe taking a slightly more common sense approach to this, there to be able to help the others as they weather that. But I'd love your thoughts kind of on what the outlook looks like for the next, say, 18, maybe. Actually, yes. When I wrote the question, it was 18 to 24 months. But at the pace at which things are being announced, I feel like maybe we could go 18 to 24 weeks and it would be a whole conversation.
Well, I agree with you on the timing. I mean, we are busy, and we're not just busy clinically, we're busy building. We're going to introduce more solutions this year than we have in the life of the company. Wow. So, we've been historically profitable for the vast majority of our time, and profitable for the last 3 years, and we put that money back to work into innovation. And so the tailwinds of RHT, the access model, are significant. They're really, just as we saw in May of last year, the hue and cry appropriately of people, 22 million people losing Medicaid, like, oh my goodness, it's a nuclear winter, right? And now on the other side, we see, oh my goodness, this is an opportunity to really invest in scalable architecture and infrastructure that hasn't been done in 20 years, 30 years, really. And so, that's what really keeps me going. And, when I talk to state Medicaid directors, or I talk to system leaders or FQHC CEOs, I am hearing them feel like the clouds have parted, that there's an opportunity. And so then you get back to, okay, so what are you going to do with it? And I see teams moving. They're doing things. They're innovating. They've had the plan on the shelf. They've not been able to have the money. And now people have the right to actually innovate in behavioral health. And so I'm incredibly excited by that. And we get to see as a sidecar and be a part of many of those projects, which I love. And we will continue to curate lessons learned. And we sponsor a lot of customer-led webcasts just for people to talk about best practices and promising practices. Because we think it's like part of our job to get those stories out. They're not proprietary stories in any way. Yeah. So I really like, the community of practice that's really starting to crank up in behavioral health.
Yeah, it's exciting to see. I kind of came to healthcare myself from the behavioral health side of things, and actually did several events in Medicaid and Medicaid managed care, and then behavioral health outcomes, and kind of dovetailing to predictive modeling, and then insurance and all this. And it's like it all sort of is coming together in this space now. And I guess to some degree it's AI that is helping that happen, because even we did some work around social determinants of health years ago, and felt it was like there was the interest, there was the common sense behind it, but the financials just didn't add up. But now that the technology is cheaper and more powerful, some of those add up now in a way that's making it possible. And it's exciting to see. And I feel like you might have just answered the last question, but we'll go to it again so you can kind of reinforce it even more, or if you have another one. But we always close with kind of what's good in healthcare, right? That's since the pandemic, when we had to find as many silver linings as we could, we started with this question. So we still end with it now, but kind of what's good and what's keeping you most kind of optimistic about where we're headed.
I think that in every encounter and in every system I've worked with, they are offering virtual encounters concurrent to physical at the point of scheduling natively. It's not an option, or if you can't, it's the very first question. Do you want a virtual or do you want a physical? That's the right answer, right? Consumer directed choice at the earliest moment of engagement. And so that's the one thing. And I know I experienced that as a consumer, right? And, it doesn't matter what the system is, it's really become pervasive. And so that's the one thing. As long as that is the lens, it means that the people that are thinking about us as consumers and patients are listening. They're listening to us, and they're giving options that we want. We've talked about consumer-driven healthcare for how many decades, right? But there's like a data point. There's a real tangible, you can look at it and see it and go, oh my goodness, that's a consumer-driven behavior.
Right.
So cool. So
yeah. No, and it's interesting. I mean, and I think behavioral health and how I think what will be really interesting is to see how behavioral health compares to other, other specialties and other, sort of elements of that, because I think that when I think about behavioral health and kind of sort of therapy and management, and that access and the time out. I mean, I live in Los Angeles. The time to go to doctor's offices is it's a 3-hour endeavor, no matter how close or how far, rural or not. And so that the convenience element of what's so important to all of this, and what makes consumers sort of make those choices is so important. And obviously there's a spectrum of the level to which people can have that choice and when, but it's good to see that Iris is kind of there and available throughout that spectrum. So well, it's been great to hear about it. Tell our audience, of healthcare leaders, how they learn more about Iris and kind of get in touch.
Yeah, Iris Telehealth.com. You can find me on X. You can find us everywhere. But iristelehealth.com, come see us. And thanks to everybody out there who's listening for what you do to take care of patients. It's definitely, you need far more of us here doing it than we have today. So God bless all.
Oh, absolutely. Well, thank you so much, Andy. It's a pleasure. Thank you to our audience for listening. Great conversation, around this, sort of struggle to keep pace between behavioral health demand and access and kind of the technologies that support it. So exciting to hear and see, what Iris is able to do and achieve over the next few months and few years, and appreciate the work that you're doing there, Andy. Thanks again. This is Megan Antonelli signing off from Digital Health Talks.